Boa tarde a todos. Sejam muito bem-vindos ao evento Cuidado, de Saúde baseado em Valor e a Sustentabilidade dos Sistemas Universais de Saúde, promovido pelo Tribunal de Contas da União. Informamos que a participação do público na transmissão pelo YouTube será realizada via chat. Pedimos que registrem lá suas perguntas ao longo das exposições e, ao final, tentaremos selecionar as mais representativas para serem respondidas pelos nossos convidados. Em caso de algum problema que precise ser sanado imediatamente, informem também por aquele chat, mas pedimos que deixem os que não forem urgentes para resolvermos após o evento, para as coisas transcorrerem mais rapidamente. Sem mais, passo a palavra à secretária de Controle Externo de Desenvolvimento Sustentável do TCU, Vanessa Lopes, para início dos trabalhos.
Muito obrigada. Boa tarde a todos que nos assistem. É um prazer estar aqui hoje nessa reunião, nesse evento, que está muito alinhado com tudo que nós estamos trabalhando aqui nessa SEX Desenvolvimento. Eu sou Vanessa, atual secretária de Desenvolvimento Sustentável do TCU, e dentro dessa secretaria nós trabalhamos com vários temas, com várias políticas públicas que afetam diretamente a vida do cidadão, entre elas a saúde. Já dizem, né, que você tem 1000 problemas, até você ter um problema sério de saúde, aí você tem um problema, porque sua vida passa a girar em torno daquilo. A saúde é um direito fundamental de todos nós, e é uma política pública fundamental, que impacta diretamente a vida do cidadão. O tribunal vem evoluindo e a diretriz dessa gestão é o cidadão no foco. E a saúde é um tema que dialoga diretamente com essa diretriz. Então, dentro da nossa unidade especializada em auditoria de saúde, nós temos um projeto de eficiência na saúde, todo baseado na entrega de valor para o cidadão. E é isso que nos move, né? É isso que tem movido uma equipe muito, muito comprometida. E não é um projeto do TCU. É importante deixar isso aqui claro, que é um projeto de muitas mãos, de muita parceria, de muito trabalho conjunto e muita colaboração. E juntos somos bem melhores. Quando a gente trabalha junto, quando a gente tem uma inteligência coletiva, trazendo várias perspectivas. Eu sei que aqui hoje nós temos vários gestores de saúde que nos acompanham. E a gente sabe o quanto é difícil ser gestor em saúde, com todos os desafios e com todos os problemas que o dia a dia, os problemas eles vêm vindo, e quanto mais eficiente a gente for, quanto mais conhecimento nós tivermos, melhor, mais capacitados nós estaremos para lidar com esses desafios que são tão impactantes. Mas eu não vou me estender muito, porque hoje vocês vão ter aqui pessoas ilustres que conhecem muito do tema em saúde, que vão poder, vão nos dar uma aula hoje, com certeza vamos aprender muito. E essa capacitação de hoje, ela faz parte de uma ação do tribunal voltada à capacitação dos gestores. Essa aproximação do tribunal com os municípios, com quem está na ponta, com quem lida com os desafios diários. Então, para a gente, é muito importante ter esse momento, e eu sei que vai ser de muitos outros, né, Alexandre? Porque nós temos muitos temas para trabalhar, muita coisa para a gente trabalhar assim de forma coletiva. Eu queria, antes de passar a palavra para a doutora Márcia Makdisse, que será a nossa moderadora de hoje, que é médica com mestrado e doutorado em cardiologia e uma pesquisadora em saúde com uma experiência enorme, que com certeza hoje vai trazer muito conhecimento aqui na moderação desta reunião. E eu queria também agradecer ao Instituto César Delo Correia, ao ISC, nosso ISC, que está tornando possível esse evento, bem como a nossa ACERI, que é a nossa área de cerimonial. E muitos outros colaboradores. Para a gente conseguir organizar um evento como esse, tem muitas mãos, tem muita gente trabalhando por trás. Não conseguiria agradecer aqui a todos, mas queria fazer um agradecimento especial ao ISC e à Seri por toda a parceria. E a Audi Saúde, que é a nossa unidade especializada em saúde, que vem trabalhando muito com esse tema, e junto com todos os parceiros que fazem parte da eficiência na saúde. E meu agradecimento, desejo de uma excelente tarde, de muito aprendizado, e passo a palavra agora para a doutora Márcia Makdisse.
Muito obrigada, Vanessa. Boa tarde a todos. Quero cumprimentar também todo o time e agradecer ao TCU por essa oportunidade. E eu vou mudar para o inglês, porque o professor Muir Gray não está com tradução, ele está na Inglaterra, e por isso eu vou conduzir em inglês, e em alguns momentos a gente pode fazer umas inserções em português, então agora eu vou mudar. I want to present Professor Muir Gray, and I want to start by saying that he's a pioneer in the field of value-based healthcare. Indeed, in 1999, he published a paper in the Lancet, which is one of the most important papers in journals in healthcare, where he already mentions value-based healthcare. A couple of many years before, value-based healthcare became known all around the world. So Sir Muir Gray is a physician. He's a professor at the Nutfield Department of Surgery at the University of Oxford in the UK. He has held senior positions in the England National Health Service, the NHS, such as in screening, in public health, information and management, and value in healthcare. He has founded very important initiatives, for example, the National Health Library, and was a strong supporter of the Cochrane Collaborative. The Cochrane Collaborative, we also have that in Brazil. That was when Professor Muir Gray came to São Paulo once, is an initiative that promotes evidence-based medicine. In 2005, Professor Muir Gray received the title of Knight of the Order of the British Empire. So he became Sir Muir Gray. This is the most important honor of the order in recognition for the exceptional service he provided to the NHS. Of course, he's also an author of several books on how to optimize value in healthcare. This is the most famous of his book. It's How to Get Better Value Healthcare. I advise all my students to read it. It brings this perspective of a value on the universal healthcare context. And of course, he published many of the atlases of variation in healthcare of the NHS as a continuation of the work started by Professor Jack Weinberg in Dartmouth. So, Sir Muir Gray, thank you so much for being with us today, and welcome.
Thank you very much.
Okay.
So I've only visited Brazil once, but my wife and I have great affection for the country. My wife's Jewish refugee cousins went from Dresden to Sao Paulo, so we've got family connections to Sao Paulo. I cannot speak Portuguese, I'm afraid. Parlo Italiano, but that's the only language I can speak, apart from English and a little bit of German. So I'm not going to tell you how to do anything. I'm going to tell you about the battles I'm having with the NHS and the problems of the NHS. And in a way, I'd like you to imagine you're just a group of people sitting in a health centre or a hospital in Birmingham or Liverpool or Oxford, and there's some members of the public there too. And I'm going to tell you what is wrong with the health service. The newspapers are full of it every day. Problems of waiting times for elective surgery, problems for A&E attendance, a whole variety of different problems. And I'm going to speak to you as, just imagine you're sitting in a hospital in the middle of Birmingham, and some GPs in the room too, some patient representatives, and I'm going to tell you what I think is going wrong and what needs to be done. I have not succeeded in doing it yet, but I'm not finished yet. So let me share the screen.
Muir, just before you start the presentation, yes, I'd like to give the audience a quick overview of the agenda we have for today.
Good, yes, please do that.
The topic is value-based healthcare and the sustainability of universal healthcare systems. And we have 3 short presentations by Sir Muir Gray, followed by a debate with the audience after each one of them. So the first presentation will be on the future challenges for universal healthcare. The second will be about the basics of value-based healthcare. And the third one will be on VBHC implementation in this universal healthcare context. So I'll have the pleasure to moderate the debate, and I want to invite you to send your questions. It can be in Portuguese or in English, and then I will translate to Sir Muir Gray, but of course, feel free if you want to send it in English. So, okay, Sir Muir Gray, without further ado, the floor is yours for the future challenges of universal healthcare.
Right, let me share the screen.
You mute me.
There we are.
Yes.
The wake of the Titanic was perfect until it was too late to do anything about it. And I'm going to tell you what is happening to healthcare in England and in other countries we're working, Saudi Arabia, for example. And we can see there's an iceberg ahead. And even though healthcare is astonishing what's happened in the last 50 years, my time in medicine, hip replacement, chemotherapy, MRI, we are heading for an iceberg. And I'm going to say a little bit about the problems that we see in the National Health Service, problems that won't be solved simply by putting more money into the way we're running it at the moment. So here's the challenge, ladies and gentlemen. Need and demand are increasing faster than resources. And although we usually think of resources in a financial sense, there are 2 other types of resource that are at least as important and have a greater immediate impact on the minds of the doctors. It's a question of time and pressure on staff time and carbon. And I'll come back to speak about carbon a little later. So, why are need and demand increasing? Well, there are 4 main reasons. Population aging, new diseases and conditions, new interventions, and then something which David Eddy wrote about in 1993 called the relentless increase in the need and demand, and the relentless increase in the volume and intensity of clinical practice. So just look at these and think what we can do to reduce them. Firstly, living longer better. And this is half of my life is called the Oxford Value and Stewardship Programme. The other half is called Live Longer Better. Now, we can actually live longer better because the aging process is not a cause of major problems until the late 90s. Her Majesty the Queen died in her late 90s and was working 2 days before her death. You need a bit of luck to avoid some diseases we can't yet prevent, but there are 3 other factors that affect us: loss of fitness, both physical and mental, a disease, much of it preventable, and complicated by accelerated loss of fitness. And I was saying actually to Márcia that I think we should take a break in the middle, because sitting for 2.5 hours is one of the major reasons for the health problems of people in their 50s, 60s, 70s, and 80s. I should say I'm trying to get sitting recognized as an occupational disease. And then that 4th factor, social factors. Too many people in England are still affected by deprivation, and ageism affects every older person. So what are we trying to achieve? Firstly, we're trying to increase healthy life expectancy. Not life expectancy, healthy life expectancy. Secondly, our aim is to close the gap between the most deprived and the least deprived. In Oxford, where I live, it's about 12 years. And I should imagine it's the same in Sao Paulo or Rio or wherever. It's the same in most countries, developed countries. A significant difference in healthy life expectancy. And the 3rd aim is to reduce the need for health and social care. You see, as we live longer, a fitness gap opens up between the best possible rate of decline, that's the top line, and the actual rate of decline. But if you haven't kept yourself fit, if you've been sitting all the time, for example, that's the red line. Now, that may not be a problem until something happens like a chest infection. And if a chest infection occurs, your ability decreases more quickly. And if you have less reserve, it's a good word, reserve, it's just like having a bank account, having a deposit, having a reserve. If you have less reserve, you lose ability more quickly, and admission to hospital often accelerates loss of ability, and you recover more slowly. And this is a major problem for us. I'm not sure how big a problem it is in Brazil. So our 3rd aim is to decrease the need for health and social care. And the top bar chart shows what it's like for a person who's lost a lot of fitness in their life and had many diseases. And we need to try and move from the top line to the bottom line. So population aging is a major cause of the increase in need and demand. But we can certainly reduce that. And someone who worked with me in Oxford, Alex Kalash, is very active in Brazil. I think he lives in Rio now. He came to Oxford, and I know he's doing good work in Brazil on living longer better. The 2nd change that affects the health service is the development of new diseases and conditions. Now, some of them are real diseases, like COVID. But the medical profession is very good at creating new problems. And this is a blood test that I had. I stupidly tripped and broke some ribs and had a blood test. I sometimes say I suffer from a disease very common in men called stupidity. And I was running for the train with my specs on and tripped and broke 7 ribs. And then I went to London to the meeting and then came back. But you see, I've had a blood test and they've measured a thing the monoclonal gamma. I look at line 4. The results of these tests show a very minor abnormality with low level presence of Ig kappa, which is too small to quantify. Your light chain ratio is also mildly out with the normal. Well, I'm on the high road here to having a bone marrow. Fortunately, I knew and was able to get out, but from this blood test, and this was just an incidental finding in the blood test because people had created this new idea called MGUS. Here's another disease, prediabetes. And again, this is me, that I had a single hemoglobin A1C of 43, but then suddenly I got an invitation to go and see the primary care nurse and join a prediabetes service. But prediabetes is a new condition that the diabetologists have invented. And we might as well just say that the problem is obesity, and people need to lose weight. But they've called it prediabetes, and a whole industry is set up now doing blood tests and blood checks and these sort of things. So, population aging, new diseases, and new interventions and technologies. Now, I set up all the screening programs in England, breast cancer screening and abdominal aortic aneurysm screening, but not prostate screening. I did not think the evidence was enough for that. But we made a decision not to introduce screening for glaucoma. But what happens now is that there's a very good bit of equipment for measuring intraocular pressure. And in England, every optometrist has got one. So now suddenly we've got a screening program for variations in intraocular pressure. And again, this is the issue of creating new problems when the health service can't even cope with the problems that it's got at present. And this means sometimes that people get referred to hospital and get treated where there is little chance of benefit. That's the case with many people with raised intraocular pressure. Here's another problem that's emerging, polygenic risk scores. And you can buy these in the chemists in Oxford. But this is a big study in the British Medical Journal. And it said polygenic risk scores perform poorly. Strong claims are made about the effect of polygenic risk scores on healthcare. They seem to be disproportionate to the performance. Now in pharmacies in England, you can buy genetic tests, none of which have been approved in any way on the basis of evidence. People have the genetic test. And I'll come back a little bit later to say what I am proposing we do with members of the public, with citizens. They have to accept responsibility for the survival of universal healthcare, namely the NHS. So, population aging, new diseases, and here's another example of new diseases. I don't need to worry about reading the screen here, but this is a blood test I had done. I'm what's called a silent shopper. The nurses in my health center don't know what I do. So the nurse said, oh, this is for cholesterol, because I had a heart attack 12 years ago, and I'm on statins and many other drugs, which I take. I take all of them. But this is a blood test taken. I've just called, time for your annual blood test. So I went down to the health center and put my arm out and got a blood test. Then I phoned a week later and said, could I see the results of the blood test? And the nurse said, well, they're all normal. I said, yeah, I'd still like to see them. And what you can see here is that there's liver function tests, renal profile, serum thyroid level. Funnily enough, cholesterol is not measured. But here, because they've got a wonderful machine up in the Oxford University Hospital, they've introduced liver screening, kidney screening, and thyroid screening, none of which have any evidence of benefit. And all of which, it's amazing actually, in 25 tests, I don't have one positive. And then I'd be, added to the waiting list for hospital clinics. So, population aging, new diseases, new technology. And the fourth factor is this very interesting idea from this great chap, David Eddy, who was an epidemiologist in America. In 1993, he wrote this. He called it, and I didn't check this with the translator, but I think it's fairly straightforward. It's the relentless increase in the volume and intensity of clinical practice. And people are saying to me, young doctors now, it may be that they're nervous about maybe it's defensive medicine, but they are certainly ordering many more tests much more quickly, sometimes before they've spoken to the patient. So I think it'd be quite useful, Márcia, if people could put in the chat other examples they know about new technology increasing workload without value, or new conditions that people are talking about in Brazil. So, what are we going to do? Well, we have to carry on with these four factors. Prevention, evidence-based decision-making, and we set up the first evidence-based center in the world in Oxford in 1995. And the evidence was from the Cochrane collaboration, which was set up about a mile from where I'm sitting now. And we have to improve outcome by increasing quality, safety, and increase productivity. These are all essential, but they've not addressed three big problems. So we have to look ahead. We have to look through binoculars at the future. And this is a wonderful quote from the inquiry into Titanic, isn't it? Supposing you'd had binoculars, some people say they didn't give them binoculars to save money. But there's a story that binoculars were locked away and they couldn't find the key to the cupboard. We could have seen it a bit sooner. Senator Smith, how much sooner? Mr. Fleet, well, enough to get out of the way. So, here's the first of our lookouts, Avedis Donabedian. And died about 10 years ago, an Armenian, and worked mostly in the United States. And he, in 1965, he published a big article on structure, process, and outcome. And then in 1980, he published his 3-volume book on quality assurance, assessment, and monitoring. See, what he said was, as you put more money into healthcare, the benefits go up, but then they flatten off. I'm not sure what the Portuguese is, if, the law of diminishing returns. So I didn't brief the translator beforehand, but it's probably something very similar. The trouble with healthcare is that the more healthcare you do, the more harm you do. Now, high quality healthcare does a little bit more harm, a little bit less benefit, but that's the position in healthcare. And what Donabedian did was this, which I call the most important picture in healthcare. He subtracted harm from benefit and found there was a point of optimality beyond which there was overuse and waste. We'll come back to waste later. The third problem is underuse. Underuse of high-value intervention will result in preventable disability, death, and inequity. Inequity. That's unfairness. And here you can see in England, at the left-hand side of the scale, are the levels of hip replacement in the poorest sections of society, and the right hand is the least deprived. And this is just NHS joint replacement. I mean, if you think of private joint replacement in England, there'll be none in the two left-hand columns, but there'll be huge numbers of orthopedic replacement in the most wealthy. So here, this is the issues that we see this huge variation in healthcare, and it shows both overuse and underuse. And this is now coming on to think about the variation. And here's the other lookout, Jack Venberg, who died last year. And he talked about unwarranted variation, which is variation in the utilization of services that cannot be explained by variation in illness or by the explicit preferences of patients and populations. And he published his revolutionary Atlas of Healthcare, which inspired both the NHS Atlas of Variation and Márcia, over to you for a Portuguese interlude to let people relax.
Ok, thanks, Muir. Então, eu vou voltar a falar em português porque o professor Muir Gray foi o grande incentivador de que o Brasil fosse o primeiro país de renda média a ter um Atlas de Variação em Saúde, né, lançado em 2022. Muir, can you move the slide, please? Yes. Então, eu trouxe alguns exemplos mais para a gente pensar em como olhar para os dados para além da média. E a variação no nosso Atlas de Variação em Saúde, ele apresenta ao longo das regiões. Então, se a gente olhar, por exemplo, a proporção de partos cesáreas no SUS, nós estamos falando, entre os estados do Brasil, de 28% a 55%. Então, tem estados que fazem 55% de cesáreas. Mas olha o gráfico da direita, se eu for olhar as regiões de saúde. Lembrando que o Brasil é dividido em 450 regiões de saúde. Aí eu encontro serviços no SUS com 84% de cesarianas. Por mais que a gente entenda que existe uma preferência, é difícil justificar e a gente deveria entender por que isso acontece. Em outros lugares tem 19%, mas será que algumas mulheres estão deixando de ter acesso quando elas precisam? Então aqui se trata realmente de entender essa variação. Next, Muir, please. Além disso, se a gente olhar, por exemplo, no AVC no Brasil, vejam que onde está mais branco, existem regiões, na região norte do Brasil, em que nenhum paciente foi tratado com trombólise, um tratamento de nível 1 de evidência, de nível A de evidência. E outros lugares, 9%. Agora, olhem para o gráfico da direita, a mesma região norte, onde eu tenho menos... Alexandre, vocês conseguem me ouvir? Tá tudo certo? Ah, tá bom. Então, nas regiões onde nós vemos que não há tratamento com trombólise para o AVC, é onde está mais azul na mortalidade. Portanto, se você tiver um AVC na região norte do Brasil, a sua chance de morrer é até 34%. E se eu tivesse AVC na região sul-sudeste, a sua chance de morrer é 12%. Observem o tamanho da iniquidade que nós enfrentamos. Próximo, Muir, por favor. Next, Muir, please. Podemos olhar para uso de recursos, hospitalização por insuficiência cardíaca. Insuficiência cardíaca não deveria internar, a gente deveria ter um cuidado ambulatorial. 5 vezes. Então, em algumas regiões, 49 internações por 100 mil habitantes, em outras, 238. Ou a duração da internação por infarto, em algumas regiões, 3, em algumas regiões, 14 dias. Next, please. E, finalmente, o último exemplo, por exemplo, gasto com quimioterapia no SUS. Região Norte, com gasto 5 vezes menor se eu olhar o estado, mas se eu olhar a região de saúde, 50 vezes a diferença. E é muito difícil dizer que na região norte não tem câncer, por exemplo. Então, esse novo olhar é que o Atlas de Variação em Saúde, né, que é esse que o professor Muir Gray citou aqui do Brasil, a gente tenta trazer questões para que nós, como gestores, possamos enxergar as oportunidades para que as melhorias aconteçam. Thanks, Muir. Back to you.
So, just to go back to look at this wonderful, terrifying map and diagram, the important point is that people have no idea, health boards, for you it's states, for us it's called integrated boards, they have no idea where they are in the distribution. And if they're at the left-hand side of the distribution, is that right for their population, or is it overuse? Remember the Donabedian curve, overuse and waste. And even chemotherapy can be overused. So the question needs to be asked for everything. And if the right-hand side, they need to ask, is this correct for our population, or does that represent underuse? And underuse is almost always complicated by inequity. Namely, the least deprived subgroups of society are getting much less than the most deprived. The most deprived are getting much less than the least deprived, because the least deprived are people like us. We're very good at working the system and getting our way. And in England, there's also a very practical side that we can take a day off work without losing pay. So we can take time to go and look things up on the internet and do things. So this is a wonderful document. And I just wonder again if you'd put in the chat room examples of overuse and any thoughts you have on the Atlas. The Atlas is very important, and in my view should be followed up by atlases for specific subgroups of the population. An atlas for diabetes, an atlas for heart disease, an atlas for mental health, because we have to get it down from the level of the state as a whole to thinking of the various program budgets, and we'll come on to that. So, what we've seen is a number of paradigm shifts. Effectiveness, that was the Cochrane collaboration. And we launched the Cochrane, Archie Cochrane wrote his book, Effectiveness and Efficiency, in 1972. So that's about 50 years ago. Evidence-based, the evidence-based center was opened. The book was published in McMaster University in Canada, and the center was opened in 1995. Then cost effectiveness started coming into the research agenda, not just effectiveness, but cost effectiveness. And then from in England, and I'm sure it'll be the same in Brazil, in the year 2000, two important reports were published by the National Academy of Health in the United States. One called Crossing the Quality Chasm, and another called To Err as Human, about mistakes. So from 2000 on, we had the quality and safety, with efficiency being part of quality. But the new paradigm, which we have to have, is value-based healthcare. Now, what do we mean by the word value? And I'll just very briefly go through. This is the G20, and the G20 discussed this when it met in Brazil last year. So Brazil has signed up to these. Somewhere, Márcia and I have been trying to find out who signed up from the Ministry of Health. But the G20 was in Brasilia last year. And this is firstly, personal value. Is this treatment, did it help the persons reduce the problem that was bothering them most? This is not, did it bring down their hemoglobin A1C? It's about personal value and the problem that was bothering them most. Then there's something called allocative value. How we spread the money across. So once the money gets to the level of the state, or in our case, the Integrated Care Board, and I'll come back to this a little bit later, is it allocated and spent with an optimal allocation? Thirdly, technical value. And this is quite a long definition because we want to make clear this is much more than productivity and efficiency. Efficiency is outcomes over costs for the patients treated, but technical value takes the whole population in. So not just the cost of hip replacement, but all the people with hip pain. How we help all those people who don't even get to hospital. And then this interesting issue of social value, which I'll come back to. So here's allocative value. Now, we haven't yet, I nearly achieved this 10 years ago, but then the government changed and it all went backwards. So what we have is a pattern of spend that's the result of 70 years of drift. In one population, the respiratory physicians were very, very good at building up their service, so the money flowed to them. You go 20 miles down the road, and the cardiologists were very good, so the money went to them. Although we've talked about commissioning in the NHS, we have not done it properly. And we've gone backwards in the last 10 years, as I'll show you later on. Then once there's resources for respiratory disease, and then remember resources is money, carbon and staff time, what's the next level of distribution? So here you can see a move from asthma to COPD in a population. And then the next level of allocation is the various bits of a pathway. And we did a project in London where we shifted resources from triple drug therapy to smoking cessation and rehabilitation. These are three completely separate budgets. And I just said I'd say a little bit about social value. And I'm not sure if Brazil's signed up to this. This is a thing called the Anchor Institution. And the Anchor Institution is doing things for your local community. For example, making sure that local businesses get the chance to bid for and win business, as well as big companies, because they'll employ local people, and that will improve the health of the local population. Also, simple things like, can the hospital support voluntary groups, give them free meeting rooms, for example, so patient groups can meet and do things. Márcia, do you know if anchor institutions are a feature in Brazil? Have you heard that phrase?
Not that I'm aware of, Muir. No. I don't know if Alexandre has any idea, but I don't think so.
Yeah, it's an international, and not all hospitals have signed up yet, but it's a very interesting approach. I know one hospital in New Zealand where they really try to recruit nursing students and medical students from the poor areas of the population they serve. So they go out and really try to get local people to come into the health service, poor local people. Now, the other side of value is waste. And traditionally, waste is what you put in what we call a waste paper basket. More recently, it's due to low productivity. But there are two new types of waste identified by the OECD. One is where interventions do not achieve outcomes that matter. So the last two people I spoke to who did cataract operations, when I asked them what difference did it make, they said, oh, not much. They undoubtedly had cataract, but it had just been picked up in the optometrists, and they had very good operations, but they didn't really have a problem. And when I last had my eyes tested, they said, oh, you've got cataract. And I could feel myself being put on a conveyor belt. I said, well, what proportion of people my age have cataract? They said, oh, almost everybody. So it doesn't, the outcomes do not matter. Or, of course, they may cause harm. And then this last, number 4, waste due to opportunity costs, where it would give more value if used for another purpose, switch from triple drug therapy to rehabilitation, for example, or switch from cardiac to respiratory, or vice versa, depending on local approaches. Now, I'm going to ask Márcia to say a little bit here, because the glossary that we're produced in partnership with our centre, she's a partner of ours, of course has got these aspects, but it also, there's this very clear distinction that we need to start thinking about the distribution of resources. And I say we have not allocated in England, it just happened. Márcia, would you like to say anything about the Portuguese translation of the word?
Ok, thank you, Muir. Então, só um momento de reflexão, o professor Muir quis colocar em português exatamente para a gente refletir sobre o que é desperdício, né? Como custos de oportunidade, ou seja, todo o desperdício é toda intervenção que ele não faz sentido para aquele grupo da população onde ele está sendo usado. Então, ou eu estou usando para um propósito diferente, ou eu deveria usar em outro subgrupo de população, mas não aquele onde o recurso está sendo implementado. Então, desperdício em paralelo com pertinência do cuidado, né? Tanto para o uso adequado, quanto para aquela pessoa que deixou de ter acesso para uma estratégia que ela teria necessidade. Thanks, Muir.
Okay, so it's the word waste in English is quite a difficult word, but I find it quite a good word, and it's now been adopted by the NHS in England as meaning something that is different from low productivity, which we'll come back to discuss. So that's the future. Márcia, I'm going to stand up, and I think everyone could stand up or have a stretch, but let's take a bit of discussion first of all. Is there anything coming into the chat or?
Yes, we have some questions. I have many questions indeed. I'll pick a couple of them. So there is one about, so usually value is related to a procedure, and people value more treatment than prevention. So how do you deal with that? The value of prevention and how you show that?
Well, let's say, as someone who's been doing prevention all my life, it is a difficult thing because the benefits are in the future, whereas now people have the very short-term approach. And actually, I wrote this in The Lancet in 1977, when I came from Glasgow, where there are many poor people, and we're into preventive medicine. I found I was saying to people, well, if you don't smoke, then maybe you won't have a heart attack in 30 years' time. But 30 years' time meant nothing to people. In Glasgow, time finishes next Friday. You've no savings, insecure job, an insecure house. So that's one of the major problems, that it's a cultural problem. There is no language. And that's why some of the decisions we take are unpopular, putting money in prevention instead of just doing things. But that's what we're paid for, to be unpopular.
There is one question related to variation in healthcare, where Moacir says, in Paraná, which is one of the states south of Brazil,
Yep.
there are financial incentives for vaginal part labor, so to avoid C-sections. And for those hospitals, there are public hospitals. But before you answer that, so they are incentivizing financially so that you can reduce C-sections. But during your presentation, I just took a look at the map, Atlas of Variation, and I found that Paraná is number 12 in the number of C-sections, and they have a variation from 40% to almost 80%. So what could we do beyond financial incentives to help reduce the rate of unnecessary C-sections?
Yes, the evidence is that financial incentives and disincentives are relatively ineffective. It's much more a cultural problem. We'll come to speak about the culture of stewardship in the next section. And I think the key thing is not to worry too much about the cost of an individual intervention, but to take all the money for pregnancy in this part of Paraná. I don't know how many population services there are, but say there are 10. And this would include everything, might include family planning as well. And say, this is a women's health budget. To you women of Paraná, what do you think? You can fight for more money, but the money we've got, we have to decide how are we spending it best? And let's decide that. So we need to consider it in the context of an overall population budget, as well as the cost of individual interventions.
That's perfect. So Muir, you want to do a 5-minute break?
We'll keep going. I'm going to stand up.
You will stand up. Okay. So I think we should, because of the time, maybe we should move on to the next presentation, which is on the basics of value-based healthcare from this universal healthcare systems approach.
Yeah. So I've got a standing desk, a little automatic desk that comes up and down, and you should all tell your manager you must have a standing desk.
Yeah, that's prevention, right?
Yeah, that's prevention. Okay. The manager will say, well, that's going to cost money, but then you say, well, yes, but it's going to prevent health problems. Now then, let me share again. How's that? Do you see the part 2, Márcia?
Yes, and just to let you know that Moacir is mentioning that we have 11.4 million inhabitants in Paraná.
Yes. Does he know how many maternity services there are? How many population maternity services?
Yes, let's wait for him to tell us.
And what I find interesting about obstetrics and gynecology is that obstetrics is very well organized from a population point of view. The outcomes are always expressed with a population database, but gynecology is a complete mess. The management of pelvic pain, for example, or endometriosis. So O&G is a very interesting specialty for that reason. Right. Now, again, imagine you're sitting in a hospital in Wolverhampton and you think, oh, what's that old Scottish man going to talk about now? Well, he told us what the problems are. So here's what he's saying we should be doing. And there are 5 stages, and I'm going to go through all 5 stages. And it might be, Márcia, we can just take a question for clarification after each one, if I'm very unclear.
Okay.
So firstly, think populations, not patients, populations. And I'll come back to that. Secondly, we need to think of, and there's about 30 populations at the level of respiratory disease, and then within each of these population segments, there's 2 or 3 common problems. So we need a system for each one. Thirdly, we've got to remember the individual as well as the population. And fourthly, we deliver through networks, not through reorganizing the structure, but through networks. And then it's the bottom of the list, but it's probably the most important, is culture change, a culture of stewardship, and we'll discuss that. So, what do I mean by population healthcare? Well, this is what we see in health services in England and Scotland and Saudi Arabia. 2 dimensions. One dimension is primary, secondary, and tertiary. And you see I've added on there self-care and family care, informal care. And the other dimension are the bureaucracies and the insurance companies. So 3D healthcare is this. We become obsessed with the various segments of the population defined by need. And the need may be a symptom, like back pain. It may be a disease, like asthma. Or it may be a condition, like being in the last year of life. Now, in England, this is the way we spend the money. And you can see this is this was actually in Oxfordshire where I live. And then so there they've got acute 442. But of course, a lot of acute is actually long-term conditions. They've got something called community care, something called continuing care, 73 million, and other programs, 15 programs. I have no idea. I cannot tell you, and no one can, the nearest £30 million what we're spending on respiratory disease or heart disease or cancer or mental health. And here's another example from the hospital service, and it just says income £1 billion, pay 621 million, non-pay 399 million. How much is spent on musculoskeletal disease? We have no idea. And this is a hospital that's got a separate campus for musculoskeletal disease. So we need to go to this. Now, I don't know, has anyone in the room heard of Bridges to Health? You see, the ICD allows you to classify for people who've only got one condition. But this is developed in America, interestingly, called Bridges to Health. And this allows you to put people in different classes. So the second left column is the traditional COPD, diabetes, epilepsy. But then if you look to the right, you can see there's column 8 is very interesting, frailty and dementia. Does anyone can anyone put in the chat room if you're using Bridges to Health in Brazil?
Alguém conhece a metodologia Bridges to Health implementada aqui no Brasil? I personally don't, Muir, so I would like to know if anyone, please put in the chat. Coloque no chat, por favor, se alguém conhece essa metodologia de segmentação da população aqui no Brasil. I asked them to put in the chat, Muir.
Yes, okay. Well, we're not really using it. We've got it in England, but we're not really using it. But the ICD only allows you to, the challenge of multimorbidity is a big challenge, and I'll come back to that. So here's, you see, the way we're trying to get people to think. To think like a supermarket. If you worked in a supermarket chain, you certainly would think about big supermarkets and local supermarkets. But the way the supermarkets think it's about the service lines: meat, fish, vegetables, beef, lamb, pork. That's like, this is the respiratory service we're looking at, with COPD, asthma, and sleep apnea. And all the budgets run this way. And of course, they vary from one place to another. In the part of Oxford where I live, there's more olive oil sold than margarine. But if you go across the river to where the poor people live, there's more margarine frontage than olive oil frontage. This is service line accounting. And I don't know if there are any professional accountants in the meeting, but we're discussing in England with our National Finance Association the reintroduction of program budgeting. I had it in there about 15 years ago, and then the politics changed and they moved to real estate funding. But service line accounting is a key issue. And here you can see, and this is quite difficult to read, but for example, mental health is the biggest budget section. And this shows both this is national, shows the average spend and the variation. So I've done that a bit bigger for you to look at. So the average spend, well, per million population is 66 million, but there's a twofold variation between the boards. For neurology, it's twofold variation. For mental health, it's threefold variation. Did you have did you manage to get any data, Márcia, for variation in spend in the atlases?
We unfortunately do not have many, only on chemotherapy, but not on conditions. We're not able to get public data on that.
Well, we've lost this, but we're mentioning people in other countries. We're going to reintroduce this because then we can get the clinicians to focus, and the states can then ask if they're allocating the resources correctly. So that's step number one, is focus on populations, not on health centers and hospitals. Any comments people would like to make, just put in the chat and we'll catch up a little bit later on that. Now, step two is to design a system. And here I've been very influenced by this man called Oliver Williamson, who got the Nobel Prize for Economics in 2008. And he said, if markets are wonderful, why do we need firms? And secondly, he said, if big firms are wonderful, why do we need markets? And his theme was that some problems are too complex for the either markets or bureaucracies, or the two working together. And what we need is a system. And a system is a set of activities with a common set of objectives. And this is at the level of type 2 diabetes or asthma or back pain or pelvic pain. And we've done systems work on all these conditions. So here's what I'd be saying, that if you were a group of people in a room in England, the diabetologists and patients, and I asked you to design the system objectives, this is what you would come up. This is what came up. To which I said, very good, 5 out of 10. Have any of you like to add objectives?
Alguém
gostaria... Put them in the chat. Put them in the chat.
Coloque no chat se alguém gostaria de adicionar algum outro objetivo. Okay, Muir, you can go ahead.
Okay, just to let me know if any go into the... Well, here, I'll show you now what we came up with.
Mm-hmm.
This is for clinicians, remember. Very, very busy specialist physicians working hard with the patients they see coming in, but we're getting them to think in a different way. So there, to measure the effects of deprivation and inequity. Do they have a map on the wall showing where the most deprived groups live? And what is the referral rate from the most and the least deprived? Evidencing a colleague from Paraná to say, if we to think of diabetes, how many diabetes services are there? Population services. And they may not think in populations yet, but what is the variation in equity? Then here we're saying to the clinicians, it's up to you to make optimal use of resources, and to the patients too. Then the next objective, to educate all the relevant professionals, for example, pharmacy assistants. So what do pharmacy assistants and pharmacists know about type 2 diabetes? It may be 10 years since they left university, but you know all about it. So you need to think of yourself as an education service. And it's always good to encourage research, because in general research, people doing research focus more on what the right thing to do is, and then produce an annual report. Any comments come in there, Márcia?
Yes, not on the questions though, so I will
No.
leave to the end of the presentation.
Okay. And then once you've got systems, we start thinking of program budgeting, and you could start then looking at, say, all the money spent on type 2 diabetes. And that would include eye services and primary care and nutrition and exercise, and get the clinicians to start thinking in this way. But we have to introduce program budgeting to do that. Then step number 3, ensure each individual makes decisions that optimize personal value. I'll just, you see, as you put more resources into a population, you treat people who are not so severely affected. So for them, the maximum benefit is less, but the probability and the size of harm is constant. And clinicians know that. So there's the clinical language: necessary, appropriate, inappropriate, and futile. So necessary means 100% of clinicians would agree. Appropriate, most would agree. Inappropriate means that, well, most clinicians would say, no, I don't think we should do that. And futile means almost all the clinicians say, no, we shouldn't do that. And chemotherapy would be an example of that. Sometimes non-oncologists criticize their oncology colleagues for doing too much chemotherapy in the last months of life instead of good palliative care. And that's why we picked the last year of life as one population group where we've done work on developing a system and reducing waste. Waste is unnecessary hospital admissions, over-treatment, and that's not to save money, that's to put more money into palliative care nursing. So just remember this, which I call the most important picture in healthcare. And you can see here that the population perception of value is the other side of the coin, as we say in English, from personal value. Now, how would you do this? Well, decision support is very important. So, for example, I don't think we should pay any hospital that does an elective operation on someone without using the explicit decision support tools, which set out the benefits and the harms, but also quite simply identifying the problem that's bothering the person most. So a friend who's an orthopedic surgeon, a woman, I was with him, and a woman came in and he said, what can I do for you? And she said, I need a knee replacement. And he said, well, what problem are you having? She said, I love gardening and I'm having trouble bending. And he said, you realize if I replace your knee, you might not be able to kneel at all. It just sometimes happens, even in very high quality service. And she said, thank you very much, and went out of the room. And whether she went to buy long-handled gardening tools or raised flower beds, I don't know, but he'd identified the problem that was bothering her most. She had a very bad x-ray, but that was not the issue. So personal value. Then number 4, deliver value through networks. And I'm a veteran of about 20 reorganizations of the structure of the health service. And of course, there's private sector issues too. But this is the century of the system and the network. So in Paraná, I'm very to know how many networks does our colleague either know there are or think there should be for either maternity, pregnancy, or for type 2 diabetes. And it means you don't have to change the structure of the health service. You still got hospitals and health centers, but you put these into networks. This is the century of the system and the network. And then finally, and perhaps the most important, is to create the culture of stewardship. And stewardship was described, it's a very old term in the Bible, of course. How do you decide to translate stewardship, Márcia?
We do not have a word in Portuguese for stewardship, so we decided to keep it in English because we already have an initiative from the government that's on antimicrobial stewardship. Em português se diz stewardship antimicrobiano. Então nós acabamos, we just kept the word stewardship.
Same in Chinese too. In the middle of the Chinese characters, you suddenly see the word stewardship.
Okay.
So I'll come back a little bit to stewardship, but she studied water in Valencia in Spain, and the farmers managing limited water, and the farmers managing the alpine meadows. And she concluded that if those using the resources are allowed to manage them, then sustainability is possible. They become stewards. And if they don't manage them properly, you get what's called the tragedy of the commons. First described actually in Oxford in 1833 by a lecturer in philosophy. And if every shepherd just puts one sheep a year on the common land, I'll make a little bit more money, I'll put one more sheep on. And every shepherd does that because they're only thinking of themselves. There comes a time when the common land collapses, which is called the tragedy of the commons. This is a book by Garrett Hardin now, but it was described in Oxford in 1833. And stewardship is to be responsible for preserving and improving something you do not own for future generations. And of course, the word stewardship came out of biblical use and into common use to do with the environment, the stewardship of the planet. So we are the stewards of the planet. What we do will determine what is happening. And this is a very important issue. And again, we often use carbon when working with doctors because they're more motivated to reduce carbon than to save money. They're concerned about their children and their grandchildren. And this is a very good report, but funnily enough, I don't think I've ever met a doctor who's read it. It was produced by our Academy of Medical Royal Colleges. And I'll just leave this up for a minute or two, Márcia. I'd like people to read this. This was written by 2 young doctors.
Okay. I'll do it in Portuguese.
Good, thank you.
Ok. Então, são 2 jovens médicos, né, que descrevem, então, qual é o guia para eu conseguir, no nível do clínico, que é quem caneta, quem consegue realmente fazer a redução de desperdício, essa conscientização que o professor está falando. Então, evitar desperdício e promover valor tem a ver com a qualidade do cuidado oferecido aos pacientes, o que é uma preocupação central dos médicos. O desperdício de um médico resulta no retardo do tratamento de um outro paciente. Então, potencialmente, pode gerar até a falta de tratamento para esse paciente, não apenas no retardo. Esse processo cria um sistema de saúde de alto valor, no qual os recursos como dinheiro, carbono e tempo dos profissionais de saúde são utilizados em outras partes do sistema. Então, não se trata apenas de reduzir o custo, mas de transferir recursos de baixo valor para intervenções de alto valor. Essa mudança cultural necessária é um chamado aos médicos e outros participantes do time multiprofissional para se perguntarem não se esse tratamento ou procedimento é possível, mas se ele de fato vai agregar valor para as pessoas e genuinamente irá melhorar a qualidade de vida e o seu processo de recuperação. Os médicos deveriam abraçar os valores do stewardship na sua prática clínica. E eu sempre falo, complementando, que cada vez que a gente vai prescrever um medicamento ou indicar uma cirurgia, a gente está fazendo gestão de recursos. E nós precisamos, profissionais da saúde, ter esta clareza de que nós somos gestores de recursos. Back to you, Muir.
Okay. But I say if I was in a hospital and health center in England, no one would have seen this report. So, just to summarize, there are 5 stages in developing value-based healthcare. Focus on populations, like people with respiratory disease, people with mental health problems, people in the last year of life. Within these segments of the population, identify the main subgroups. So within musculoskeletal, people with rheumatoid arthritis, people with hip pain, people with back pain, people with knee pain, people with spinal pain, for example. And for each of the subgroups, design a system, a set of activities with a set of objectives. Then thirdly, deliver those system objectives through networks. So I was asking Márcia, well, how many networks are there for type 2 diabetes in Rio Grande del Sul? Can we find how many clinics there are and get those clinics to think of populations, not just the patients who turn up to see them, because there'll be a big bias in terms of deprivation and who actually gets there. Fourthly, remember personal value as well as population value. So we're not just talking like public health professionals. We've got to think inside the minds of individual clinicians and individual patients. Have we found out the problem that's bothering them most? And have we helped make a decision as to whether the problem that's bothering them most needs this particular treatment? Because treatments always carry risk. Will the probability of benefit and the size of benefit, is it more important to the patient than the probability of harm and the size of the harm? And then running through all of this, the culture of stewardship. And remember, leadership changes culture, then management works within it. So enough from me, I think, at the moment. I don't know if we've got questions or comments coming in you'd like to take.
Yes, thank you. So we have some questions on data. So from Emanuele Daltro, she asked, could you talk about digital healthcare services and how it has been in your reality? Does it help reduce healthcare costs?
No, well, I don't use the word digital very often because we don't use the word electricity. So I don't say, well, let's talk about electricity healthcare. Digital is everywhere. So I do work in England with the analysts. I'm not sure what they're called in Brazil, but the analysts, sometimes they're called data scientists, but they usually are called analysts. And they're sometimes in finance departments, but sometimes they're chief officers in their own right. And these are people who are very good at, firstly, identifying the data that's needed, and then bringing together, usually there's about 3 or 4 different computer systems that we brought together, digitally, of course. So yes, digital is essential to start moving from real estate healthcare to population healthcare. And in speaking to you as a group called auditors, you've got analytic skills. What I've learned about you is you have a very high level of analytic skill, and you might be called analysts rather than auditors in England, and therefore you do need to understand how the big data sets work and how we bring together the numerator and the denominator. So, but I'd say digital healthcare, I think a bit like electricity healthcare, the word digital we're not going to be using in 5 years' time because it's there. We have to ask the right questions, and then the clever people like you can always find the answer by bringing together data from here and data from there. So if I ask, well, what's the inequity in this particular service, then a clever analyst will say, oh yes, I can do that, because we know everyone's postcode. I don't know what your equivalent of a postcode is in Brazil, but the NHS knows everyone's postcode. And there's a local authority database which relates postcode to deprivation. And we here have got primary care data about type 2 diabetes and secondary care data about diabetes. And we can show that poor people with type 2 diabetes are less often referred to hospital than people from the less deprived bits of the population. Is that helpful?
Yes, and while you were speaking, I was just considering that you have much more data than we do have. For example, if you compare the Atlas of Variation, the NHS Atlas of Variation, you discuss effectiveness because you have data on the quality of treatment of, for example, diabetes. You know how many patients have their disease controlled. We are not there yet. So the second question comes in the same direction. They said, Sir Muir Gray, you said that we have to think about the health of the population, not only about the cost of individual procedures. You said that you should place the final decision and we should share the decision-making process on the use of resources with the local population. But at the same time, the NHS is not able yet to know the spending for each one of the population segments. So should we invest more in health, in IT, in information technology systems so that we can improve the decision-making process on where to spend the money?
Yes, you need the information if you're going to make the right decision. So there may be a case that investment in IT would be of higher value than increasing the number of hip replacements, for example. But that has to be decided at the local population. And when we make decisions, supposing we were to make explicit decisions about allocating money to either cardiac or respiratory, there is no computer formula can do it. Ken Arrow got the Nobel Prize for showing, he called it the impossibility theorem. And secondly, there's no single ethical principle that we can use. Utilitarianism is often talked about in the UK, the greatest good for the greatest number. But that means you punish people with rare diseases. So what emerged from this work is that we say to the public, if I were in a bit of Sao Paulo, I'd say, listen, this is a hellish difficult decisions we're making. But none of us have got financial interests one way or another. We're not biased by our own careers or whatever. And we're going to try to make the best. We'll listen to all of you. We'll listen to bids from all the various subgroups of the population, and we'll just have to make the best we can, called accountability for reasonableness and openness and reasonableness. So that's part of the debate. So there may be it's better to spend money on computers than on more hip replacements, but let's talk about that.
Okay, so the next question is, with this current mindset across governments all around the world, is it still possible to move on and with universal healthcare coverage?
Yes, it is. But there will have to be more explicit limits set, and the citizens need to understand that. But I think the G20 and I know Brazil is committed to universal health care. Insurance companies have a part to play, and there are a lot of insurance-based health care in the UK, and people are paying to get quicker access to, say, hip replacement. But we do need to think that for treatment of cancer and heart disease and other things, we need very good emergency services that I don't see the insurance-based alone being able to do. So I think a commitment to universal healthcare is still a key hallmark of all of the members of the G20, with the exception of the United States of America, even before Trump. Now in America, there's very good little populations. You know, there's the population of the Cleveland Clinic, and there's the various other groups like that. But they are not they're not taking the whole population, a geographically defined population. And that's the difference between America and the rest of the world. And in America, waste is probably 15% in all countries. America, waste is maybe 50%.
Perfect. And the last question for this part. So we reached a crossroads here where technology get us all connected all the time in social media, for example. And at the same time, such connections sometimes demonize primary care. So how can we overcome this challenge?
Well, it's, again, I think it's moving away from primary and secondary care, remembering that self-care is actually the most important type of care. And then secondly, it's care by family and other members of the community. Then thirdly, primary care. Then fourthly, secondary care. And fifthly, super specialist care. So that's where the population comes in. And I think we are not putting enough into self-care in England. That people are not getting enough good information in the right way. And of course, with a thing called the internet, we can do something about that. So there's a digital theme there. So how are we doing, Márcia? We got half an hour to go?
Yes. Now, we can move to the third presentation on implementation of value-based healthcare in the universal healthcare.
Okay. Well, I think everyone should stand up for a minute and then...
Okay.
Get yourself a nice standing adjustable table.
I will.
Right, here we are now. Sharing screen. Right. Here we go. So this is just to tell you what we're doing in England. So there's 42 what we call integrated care boards. So they're all about 1 million. And then we found it helpful to think of hospital networks. So in the board I live in, there are 3 hospitals. each with a population of about 600,000. And of course, these hospital-based populations are very long-standing because they're defined by the way the buses go, even before the NHS. There comes a point, if you live in Oxfordshire, where it's easier to go to Reading for shopping than to go to Oxford. And therefore, a proportion of the Oxford population go to the Reading Hospital. And then we've got about 1,200 primary care networks. And these are really run by the GPs. And they've got nurses and others working there. So we need to think of not only their internal controls, but how do we audit their performance? And I'll just tell you what we're doing. So firstly, there's a need to ensure that all the processes are legal, e.g. for procurement. And there's some very clear rules about how you can do things, how you employ staff, that sort of thing. There's also, of course, the NHS has got its own rules. And these aren't covered by law, but they've been developed over the years. And if you didn't follow these rules, you'd be disciplined by your chief executive, not by the law, but your chief exec. So things about, this would include a lot of staff things about how you appraise staff and how you promote or staff, or how you discipline staff. So there's process. And then we come on to productivity. So productivity is outputs over inputs. So a couple of obvious examples: average length of stay, percentage of drugs which are generic, management cost effectiveness, management costs, IT costs, for example, which would include the staffing. So I'm not sure what you use in Brazil, but these are fairly standard worldwide, productivity. Then we move on, and this is where we're at an early stage, but we've got some ways of doing this. We're measuring outcome. So outcome, this was based on Abadian. Outcome is different from efficiency is different from productivity because it measures outcomes, not just the number of beds used or the amount of money spent, but it measures outcomes. And we're starting to collect outcomes, and I'm sure you are too. And there are quite a number of standardized outcome tools for hip replacement. There's a thing called the Oxford Knee Score and the Oxford Hip Score. There's a lot of these tools now available. They're not collected routinely at the moment. And what I was saying earlier about collecting the outcome as related to the problem that was bothering the person most isn't done very well, but I think it should be done. I wouldn't pay a hospital unless it had ascertained what was bothering the person and then asked them at the end of that, is the problem that was bothering you most better, no better, worse? But I haven't done that yet. So here are the sort of objectives that we're encouraging people, and each of these will have outcomes, you see. So this is the system we did for in Dorset, about 600,000 population. So many of these are process measures. They look improved uptake and completion of pulmonary rehab. So these are still pretty weak on outcomes. These are what Avedius Donabadian, remember, talked about structure, process, and outcome. And here we've got a combination, but these are mostly structure and process measures and not outcome measures, which is what we need to introduce. Here's another project we did for people with atrial fibrillation. And we developed a system for atrial fibrillation and produced an annual audit form. And a number, we haven't done this nationally yet, but we will do. And here's what an annual audit report looks like. Again, setting out clearly the population size, number of practices, and these are mostly process. These aren't the number of people having strokes, for example. That's more complex. We need to develop a link to the emergency admission database, which is being done. So these are mostly process measures. Look at these. I can't even remember what some of these things are. Percentage of patients with C2 scores greater than 2 on oral anticoagulant. So these are process measures. Remember, I based on a median structure, process, outcome. So we need to move from process to outcome. And this is also a measure of structure here. So there's 9 practices and 9 are participating. They haven't put 100% in brackets after line 5, but that's what they should have done. So technical value is broader than this. I'm going back to what I said earlier about technical value. It's broader than the Harvard definition of value, which we would call efficiency, because it's not in a population committed to universal health care. And it includes asking, could we spend the money in a better way? And I say, when we did this in London with COPD, we decided to spend some money not on drug treatment, but on smoking cessation, which is a completely different budget, because that was better for the population. So that's technical value. Then we need to think a little bit about the Health Outcomes Program. Márcia, would you like to say a little bit about this?
Eu acho que bom exemplo que nós temos no Brasil para a coleta de desfechos de uma forma continuada é o programa da Associação Nacional dos Hospitais. Desde 2017, nós temos 16 hospitais coletando desfechos usando padrões internacionais como ITIOM para insuficiência cardíaca, osteoartrose de quadril e joelho, AVC, câncer coloretal, câncer de próstata localizado e câncer de mama. Se nós formos olhar especificamente a osteoartrose de quadril e joelho, que o professor tinha citado, nós temos 11 hospitais hoje no Brasil coletando. E qual é o nosso desafio deste ano junto à Associação dos Hospitais? É construir um dashboard de valor, porque nós sabemos que só medir desfecho não é suficiente. Então, como é que nós trazemos também essa visão do uso dos recursos, dos drivers de custo e dos processos que impactam em desfechos e custos? Então, esse eu acho que no Brasil é um grande exemplo, mas ainda são dados muito pouco utilizados para programas de melhoria e redução de desperdício e melhora dos desfechos. Back to you, Muir.
Yeah, so, I mean, the Americans have developed very good outcome measures, but their outcome measures are used for the patients who can afford to go to the hospitals, whereas what I think what we're doing is using those same outcome measures for the whole population, and adding to that measurement of deprivation to see if there are different access and outcomes for different groups. So here's the sort of questions. Now, Kent is it's just southeast of London, population about 1.5 million, and it's got 4 hospitals in it: Dartford, Medway, East Kent, West Kent. And these are the questions that I'm putting to them, which they can't answer. They could nearly answer it 15 years ago before the government changed, but I'm back on the case. But you can imagine, and I was asking about Rio Grande del Sur, about could you do this? So how many hospital-based populations are there? And what are they spending on respiratory disease in these populations? What are the outcomes? And then if you don't have outcome data, simply ask them about activity rates. So there's 4 populations in Kent, but they've never actually measured cataract surgery with a population denominator as opposed to a patient denominator. So that's what we're doing now. And I had a meeting today, and I said, we're just going to keep asking these questions politically because Kent is probably spending £2.5 billion a year, but can't answer these questions. And no other boards can. It's one of these integrated care boards. So we're thinking of 4D healthcare. Remember, 4 dimensions: personal, allocative, technical, and social. And then finally, what we're saying, I'm working a lot with the analysts, and I said that why don't you call yourself intelligence officers? Because the analysts are very good at talking about the past, but in the military, the intelligence officers, who are just like the analysts, but they know that the general is not interested in just being told, oh, there are 50 tanks who came here and at an average of 17.3 miles an hour. The general wants to know what's over the next hill. So how do we do that? Just to finish, population-based variation. And this is from our English atlas, but you've got a wonderful atlas, and Márcia, I know, is planning to develop other atlases. And these pictures are very dramatic, and paper is very dramatic. I did them all on paper because you can't click away from paper so easily as you can click away from a website. Report on equity. Every report should have something on equity. Report on carbon. And as I say, carbon motivates clinicians more than finance. So, and 80% of the carbon in a health service is from clinical work, from the research, manufacture, use and disposal of drugs, equipment, and on travel, staff and patient travel. So in our country, only 20% is heating, lighting, and air conditioning. That may be different in Brazil, but carbon is mostly clinical. And we have a Centre for Sustainable Healthcare in Oxford, which we very much like to link with you in Brazil. So we set this up. I set this up about 15 years ago. I called it Centre for Greening the NHS, and it does do. We've got an NHS forest with about 100,000 trees, but also offering this type of training is very motivating. And if you reduce carbon, you almost always reduce finance. Introduce program budgeting, I've spoken about before, and then give the clinicians responsibility for the program budgets. And then training. And we have a training program, and it'd be very good to offer the training program to all the auditors to start off with. And this is what I show when if I was speaking to you as a group in a hospital. I say, I'm going to offer you training. This is what I want to do. I want to rewire your brains. Do you know what this is? This is a green box at the end of a road in Oxford with the telephone. How these people manage to do this, I never know. But this is an old-fashioned telephone system. So I always take a photograph when I see it open. This is your brains, and I'm going to make different connections. And here's the sort of things we need to be able to answer and talk about. And I would actually look to you as an organization that should change the culture of healthcare in Brazil. You're very influential, I know, from what Márcia has told me. So to finish, the view from the bridge in the Titanic was fine. The engine room, all the data and the engines is all perfect. Everything was terrific. Pile on more coal, go faster, look at the data. But that was up ahead, and analysts we can see the future and give the leadership to create the culture of stewardship. So enough from me, more than enough from me. Márcia, I think time for people to go and have a walk and get back to work. But any points coming up that you'd like to read?
Yes, there are some questions from the audience that I'd like you to answer before we finish. So there is one that says that the Ministry of Health from May this year will change the way they pay for primary care. consider the following up of vulnerable populations as part of this additional payment. So
Yes.
how do you see that?
Well, it's got these sort of incentives have got a part to play, but people who go into healthcare are going to it for the best of reasons. And I would put more effort into getting the whole budget, give them the responsibility for the whole budget, and then have an objective for, say, the vulnerable subgroup of the population, and get the professional to tackle that in their population using resources to best advantage. I'm not greatly impressed by the evidence about the benefits of incentive for penalty payments.
But do you agree that, okay, we have to invest in evidence-based protocols, we have to invest on stewardship and a change in mindset?
Yes.
Do you consider there is a role also for financial incentives to help recognizing best practices or paying better for those who do a better job or produce better outcomes, not only reducing costs, but improving outcomes?
Yes, all I'm saying is the evidence isn't very strong for that. And a much bigger problem is the variation in spend at the moment and the variation in practice. So what your atlas showed won't be solved by a few changes in financial incentives. The variation is much bigger than that. It's just people haven't a clue what they're doing at the moment. So I'd start with the knowledge, and if I were investing, I'd want an atlas for every population subgroup, and I'd want you to produce one within 2 years.
Perfect. Muir, could you clarify a little bit more about the question on the difference between systems and networks? Because I think that's you provoked us to think that this hierarchical primary, secondary, tertiary care will not lead to be more efficient in terms of cost and outcomes, so you need to build systems.
Yeah.
So what is the role of systems and how do they connect to the networks?
A system is strategic. Think military now. I've not been in the army, but think of military. So let's take type 2 diabetes in Brazil. What are the objectives we're trying to achieve? We should all be working to the same objectives. What is it we're trying to do? How we achieve those objectives, we leave to local operational commanders. And the way you do it in Rio Grande do Sul will be different from the way you do it in Paraná, and within Paraná, there'll be also, because the local commanders, as they say in the military, have to take into account local history, geography, and politics. So the system is a strategic objective. The network is the means by which those objectives are achieved.
So just to summarize, if we put this into practice, we will build a system for low back pain.
Yes.
All the specifications of the system, how we are going to work together as a multidisciplinary team, what protocols to be followed, or what metrics should be measured. That's
the one, yeah. The system, you're not building, you're designing a system.
Yes, you're designing a system.
Designing a system
Perfect.
With all the metrics. And then you say within Rio Grande do Sul, well, I wonder how many different musculoskeletal services there are here. And how many back pain clinics are there? And then you, as the Governor General of Rio Grande do Sul, would say, well, it looks to me as though there's 8 or 15 or whatever. So, ladies and gentlemen, here are the objectives. Now, off you go and give us your annual report in a year's time.
Perfect. Then we design the systems, all the specifications are there, and then I will build the networks that will follow the system specifications, but they are different because you have different needs in different locations, right?
Different history, geography, and politics, yep.
Perfect. So we design systems, we build networks, different networks following the same principles of the system. Perfect. That's pretty much what we are doing, inspired by you.
Yes.
With the Unimed, right?
Yes, sure.
Agri. So we built this back pain system, and then we are operating we're building the networks. Perfect. Then there is one question here about the financial payment, the payment system in the NHS. Do you still operate on fee-for-service, or do you use bundles or capitation or any other payment model?
It's usually a payment for hip replacement or in secondary care. There are different ways of doing it, but it's fairly standard around the world, or some sort of payment system for an episode of care. We don't go into detail about costing how many MRIs you've got or whatever. It's just you've had 8 days in hospital.
So, but you do have capitation for primary care, right?
Yes, yeah.
You have the capitated system, and then for high complexity, then you have per episode payments.
Yes, but there's a separate budget for the hospital. Okay. So there's a budget for the hospital, budget for the mental health service, and then primary care.
So it's budget, like a global payment. So the hospital will have a budget for that year.
Yes.
And then that's why you have some patients waiting for a procedure, because you have a waiting list, because the resources are finite, right?
Yep. Yes.
So just to make it clear for the audience, so you have capitation for primary care, but they do operate on budgets.
Yep.
And then you have the budget, global budget for the hospitals, and that will finance the secondary and tertiary care.
Yes. Yep.
Okay.
Yep.
I don't know if Alexandre or anyone else have any other comments or questions. If not, then I just would like to ask you to do a little bit more on building capacity, because we have this current mindset, and changing culture it's not an easy task. So, and you said you have to train 50 people in 1 million,
500, yeah.
500, yes, in every 1 million. But how should we start that movement? Is it the government who should bring all these new mindset or this new educational platform? Should we start from the medical school? How can we start this movement that will get new healthcare professionals and new people who will manage resources to be aware of this need for sustainability of the healthcare system?
Well, one of the principles of one of the management gurus is first who, then what. So you find someone who's keen, might be a minister of health, might be someone in the finance department. But I think actually the auditors could have a terrifically important contribution by asking questions that people cannot answer, called interrogative selling. So how much are you spending on respiratory disease in Rio Grande del Sul? You mean you don't know? That's about 300 million, and you don't know. And you don't know what the variation is between the different, and how you compare with, how does Sao Paulo compare with Rio de Janeiro in spend on heart disease? You mean you can't tell me? Well, we, as auditors, for best value, we're going to ask these questions, and you bloody well better get your information systems working to answer them.
Oh, that's great. And another question I'd like to ask you is, when you start educating people, they will start asking for time protected, so that they can help with the transformation to occur. And we know that time is a much more value asset than money.
Yep,
so,
it's the finite resource. Yep.
So do you see any big change in getting time for the clinicians and those who manage resources to dedicate to this new paradigm? Because they are so absorbed in this volume-driven model that we have right now. How can we get that to work?
Well, let's make this the last question, because people have had enough of me 2.5 hours. My God. Well, the way to do it, what I would do, and I think I would start with the auditors, would be in each of the states, let's get a team together. This is very Japanese, maybe 10 people, finance, medicine, informatics, and if that team even met once a week for 2 hours, they start to think, how can they change the culture and how can they rewire the brains of people? Now, in a big country like Brazil, you might need, within a big state, you might need other teams at different levels. But I start off by thinking we need to develop a team within each state.
Perfect. So, Muir, thank you so much for your generosity and for staying with us for 2.5 hours.
Oh, not at all.
Thank you. So I will ask Alexandre Giro Cavalcante. He is the Chief Auditor of the TCU's Specialized Health Audit Unit, to do his closing remarks. Alexandre, por favor.
Thank you. Before I speak in Portuguese, I would like to take a moment to sincerely thank our amazing speakers for their valuable contribution today. Their insights and expertise truly enriched this event. And we are grateful for the time and knowledge we've shared with us.
Thank you.
Vou fazer alguns agradecimentos agora em português, se me dá licença. Foi muito rico, esse é um assunto de extrema importância para o nosso país, para todas as instituições de controle. Nós precisamos juntos criar um ambiente propício, né, para a entrega de valor para o usuário. Não é à toa que nosso atual presidente aqui no Tribunal de Contas da União tem colocado o foco no usuário, nas pessoas, como o nosso mote nos próximos 2 anos. E nós queremos realmente aprofundar o conhecimento. A gente vai ter ainda outros contatos com a doutora Márcia, quem sabe até com o professor Muir Gray também. E eu já quero aproveitar todo o público que permaneceu até agora para anunciar que no dia 22 de maio desse ano, das 14h30 às 17h, nós teremos uma outra interação com a professora Márcia Makdisse e com os expositores convidados do Ministério da Saúde. O tema será financiamento dos serviços da atenção especializada no SUS. É claro que também terá esse olhar voltado para a preocupação com o valor em saúde, né? E eu espero contar com a presença bastante maciça de todos os colegas. Então, por favor, convidem as pessoas para que a gente possa ter um debate bastante rico, né? E é isso, eu quero agradecer a todos os parceiros, ao ISC, Instituto Cedelo Correia, que tem sido sempre muito carinhoso, muito generoso conosco aqui da Saúde, nos dando todo o apoio, propiciando momentos riquíssimos como esse. Todos os colegas do tribunal que deram apoio, como uma nossa secretária acabou de dizer no início, né? A Seri, entre tantas outras pessoas, tradutores que trabalharam aí arduamente, não é fácil, né? Traduzir 2 horas, mais de 2 horas. Agradecer a vocês, a gentileza, enfim, a todos que colaboraram e que participaram aqui, né? A Dagmar, Marília, que estiveram aí por detrás trazendo as perguntas. A Larissa também, que tem sido uma parceira de grande valor para a gente. E é isso, agradecer aos tribunais de contas, a todos aqueles que estão participando conosco. Continuem, a gente tem muita esperança em que as coisas comecem a ter esse novo olhar no Brasil, né? E agradecer mais uma vez, doutora Márcia. Acho que é isso. Algum comentário final, doutora Márcia?
Não, só agradecer. Eu acho que é uma grande oportunidade de discutir valor numa amplitude que vai além, como o professor fala, da equação de valor, não é só falar de desfecho sobre custos, mas é falar de valor alocativo, de valor social, de valor pessoal, e ter a oportunidade de ouvir o professor Muir Gray com essa grande experiência e com os enormes desafios que ele tem enfrentado. Professor Muir Gray, do you want to make any final comments?
Well, I think, as I understand what you do as a group, I would see you as a key group in ensuring the sustainability of universal healthcare. And you need to stimulate or irritate, and the atlases were designed to both stimulate and irritate. But you need to ask questions that we think should be able to be answered. I haven't succeeded in England yet, but I'm not finished yet, and we'd love to partner with you. So my guess is that the skills of your group are very good. You're also, I think you've come into the health service. You could all be making twice as much money working in private finance. You've come into the health service for the good of the health of the people of Brazil. So I would regard your group as a key group in military terms to do the leadership and the change and the combat that's required.
Thank you, Muir.
See you again.
See you later. Abraço, pessoal. Obrigado. Obrigado a todos.
Thanks, Márcia.
Thanks, Muir.
Go and have a stretch. Have a walk. Bye-bye.
Bye-bye.